Hey, hello, hello, hello. Welcome back to our amazing web series, The Red Pill versus Blue Pill. My name is Dr. DeLon Canterbury. I am your favorite geriatric pharmacist and CEO and founder of GeriatRx. So, hope you guys are doing so well. I'm off to an amazing week. I am excited to say that we have launched and finished our very first cohort of the Deprescribing Accelerator. And so it's time to rinse and repeat. So our second cohort will commence next month. And you may be wondering, is this right for me? Who is this quite for? And so I may as well at least give you a little bit of background on why I'm here today in front of you, sharing my passion behind deprescribing and why this has to be at the forefront of healthcare with pharmacists at the helm, along with other healthcare providers who have that very same passion. So I want to show how you guys, yes, you, patients, clinicians, pharmacists, nurses, social workers, PT, OT specialists, anyone who is touching senior care patients can easily learn how to stop and spot harmful medication use within this population. I unfortunately had to see firsthand how my family struggled and suffered when my grandmother was honestly kicked out of a nursing home because of an inappropriate medication. It was ziprasidone, and the very same nursing home that was trying to manage her behavioral symptoms related to dementia gave her a prescription that literally plummeted her symptoms. And so she was sundowning very hard. I mean, she was literally wandering around the house in the neighborhood at night, knocking on doorbells. She was irritable. She was angry. And she just wasn't herself. And my grandma did not need to suffer this way. And so, unfortunately, we have a huge problem in this country with over medicating. Duh. It's clearly seen in our opioid epidemic, but we fail to realize that we just throw pills at anything. It could be a cold, it may be virus based, but here you are with an antibiotic. If I got a headache, I got to suddenly take naproxen, Aleve, aspirin, all this stuff that you may not quite need, especially if the person just wasn't drinking enough water, right? And so we're so quick to jump to a pill, yet we don't think to assess whether that very same pill is what's causing harm or maybe presenting as another health condition or masking a health condition that's worsening our patient's well-being. And so there are ways you can literally learn how to leverage and monetize deprescribing in clinical practice. Look, it's not complete rocket science. It's literally looking at ways we can actively and actually progressively integrate pharmacists as well as other deprescribing advocates into our health care models. So you may be wondering what kind of prompted me to launch here today to be in front of you talking about deprescribing. Why do I want to teach other clinicians how to do this and leverage this? And the reason is I am sick and tired of hundreds of thousands of people dying from preventable adverse drug events. As simple as that sounds, why must it take people being this close to death's door, right? Why must it take that? Why must it take someone being sent to the ER 2 and 3 times before we start thinking about, maybe the medications are the issue? They've been on 20 meds, but we didn't think that was a problem before. Now it matters. Like, what? Like, where's the common sense in that? And so I already told you about my grandmother and how she was overprescribed, over medicated. And it wasn't until a pharmacist in a community setting, that's right, it was a Rite Aid pharmacist, she fought and she got that medication deprescribed. That was the only reason my grandma lived to see 90 and was able to live a relatively healthier life without having those dementia symptoms exacerbated because they subsided. And it was because of one pharmacist who made one call and told the doctor to stop a medication, which again was used inappropriately to treat something that did not need to be treated with an antipsychotic. Okay. So that's my story. Let's double down. My very first patient with geriatrics was another over-medicated senior. She was a 70-year-old woman who was, again, given Seroquel, another antipsychotic, for behavioral issues with her mild cognitive impairment, and was on 36 medications. I mean, my God, why is a woman on 36 medications and 70 years old? Why? So there were a number of issues. There were clinical inertia. There was the prescribing cascade. There were multiple specialists prescribing meds, and they weren't talking to each other. There was a lack of a pharmacist. There was a lack of managing those transitions of care when she went from one office to another, or went from the hospital to a nursing home, because she did leave 2 nursing homes and eventually got back home. Why must it take such extreme lengths for us to finally say, maybe the meds are the problem? Like, it doesn't take a pharmacist to say, yo, you should not be on 36 meds. Like, no human alive should be eating over 30 to 50 pills a day. You can't even expect them to be adherent with that, right? So again, if these are just my personal story of my N of 2, my grandma and my very first patient who were over medicated, then imagine how many lives are just being written off or falling victim again to our broken healthcare system. How many people are just without an advocate, don't even have a lick of a healthcare provider in the family, or even know where to go or talk about these issues, or don't even feel the power to ask, hey, doc, can I really get off of these meds safely? That, my friends, is the problem with our sick care. And that's why we are caught in this matrix, this delusion that we are solving and giving the best healthcare in the world. We aren't. We are some of the least effective in patient outcomes when it comes to really providing quality care in one of the most developed countries in the world. We consistently rank low in that. And why is that? Yes, capitalism sucks. Yes, being greedy isn't helping our healthcare system. And we have to get out of this fee-for-service model to more value-based care. I mean, that's obvious. But we need more alignment with patient needs. We need team shared-based decision models that focus on what the patient and caregiver want. But we also got to focus on saving our patients money and time from them taking meds that send them back to the hospital. It's really not that hard. We just got to look better at things that we know are causing harm. And we know our most vulnerable population are those who are 60 and up. They're the highest risk factors for polypharmacy. Females are the highest risk factor for having multiple medications prescribed, no matter what conditions they have. So we got to address not only the health disparity piece, but we got to change our entire medication mindset, that we continue to honestly think that every ill needs a pill. Every ill needs a pill. Like, that does not make sense, especially when you're an older patient, you've been on something for 30, 40 years, your body doesn't work the exact same. You're more prone for side effects. You're more prone to have drug interactions. You're more prone to have adherence issues just because you're taking more than 5 medications. And if pharmacists know this, then we need to be adequately staffed and reimbursed to integrate our expertise in stopping this before a prescription is even written. It shouldn't have to take it going to the pharmacy and then months and months of refills, and then suddenly an adverse event happens and we're suddenly asking, why did this happen in the first place? That's backwards. That's a waste of time. That's a waste of money. And that kills the patient's trust in our healthcare system. So I'm tired of this broken system, honestly, murdering our community members. I'm tired of this broken healthcare system killing our elderly. I'm tired of nursing homes killing our elderly. I'm tired of SNFs killing our elderly. I'm tired of LTCs killing our elderly and writing it off as another, oh, it just happened. Whoops. Sorry. See, we don't care if it's a data sheet, but you care when it's your grandma. You care when it's your loved one or your mom or you're a health professional who turns caregiver. And now you see what it's like to be in those patient shoes and try to maneuver a system so fragmented, even with your doctorate, you still don't know who to turn to for help. So I'm tired of going to these conferences, going to these geriatric care groups, speaking at caregiver events, talking to these dementia masterminds, partnering with Alzheimer's associations, and literally hearing the exact same issues that happened to my grandma or my first patient. And it's always the meds. It's like always the meds. So we have a duty as healthcare professionals, as pharmacists, as nurses, as social workers. In fact, anyone who is touching a senior patient in that world of touch points in our healthcare system has a duty to stop harmful medications. And then we will show you how to do that as a part of our Deprescribing Accelerator. And so I don't believe that to be in this country, it's acceptable for us to allow 275,000 people to die each year because of mismanaged medications. It is unacceptable that we have to spend $500 billion in our country for the costs associated with mismanaged medications. It's unacceptable. It burns me to my core, again, that someone's put in harm's way when I do a med review and I see Benadryl in dementia patients, or I'm seeing Seroquel in patients who don't have bipolar disorder or any other type of appropriate indication. And it burns me when I see people over-medicated on hypertension medications, and they're wondering why they're dehydrated and falling. Like, can someone make it make sense? Again, we are in the matrix, right? We got to take the wool over our eyes and see that this enough is enough. And you have the power to change it. We have the power to change it. Nurses have the power to change it. Pharmacists have the power to change it. As long as you care about deprescribing and advocating for your patients and educating your patients, you can move mountains. You can move mountains. So when I started thinking about what do I want my providers to leave with this program, I not only want them to have the confidence and clinical skills to understand the meds and the geriatric world for sure, but more importantly, the key is saving lives. It's serving. It's serving. It's education, a little bit of training, changing some process flows you may have, maybe changing some of your automations, but I'm literally teaching you how you can monetize deprescribing. And that in a time of COVID is priceless, okay? You can do a number of things, but what I'll tell you is this: I do not want you to be burned out and depressed and anxious like I was when I was just serving up pills to people with no qualms about whether this is even appropriate for them or not. Back when I was in retail pharmacy, back when I was at Walgreens, just serving up pills, putting your name on a bottle. I hope they live this time. I hope they don't die this time from the opiate abuse that they got arrested for last month. I hope that grandbaby didn't find oxycodone in the back pocket like they did last year that had my initials on it. I'm fed up of our healthcare system, if you can't tell. I'm angry that that's my job as a retail pharmacist to sign off on bills that I know you don't need. So let's do the opposite and get them off and see how they do. In fact, 80 to 90% of people who are tapered off of medication safely don't even have side effects from stopping the med. Of course, some meds, matter, and some you may have some issues. Rare, but majority of meds you stop in our elderly aren't going to have you with side effects at the end of the day. So why the hell aren't we doing it? Period. Why aren't we doing it? Again, choose the red pill. Do it. Choose the red pill. Learn how you can not only build a potential value added revenue stream for your practice, but learn how you can truly start saving lives just by asking the right questions with our Deprescribing Accelerator. So I saw how much I hated myself when I was in that Walgreens, those four walls, or the corner of insanity and depression is what I call it. But that's where I was for the last 5-6 years prior to geriatrics. And again, I felt like I was a part of the problem of over prescribing, because even if I wanted to stop some things, I would have to have permission. I would have to basically build a case. The truth is, our system isn't designed necessarily to incentivize deprescribing, but we got some workarounds for that. We got some tricks for that. Until they catch up to the way we should deliver healthcare, learn how our program will teach you how to work around that, get some grants, maybe even have some strategic partnerships where we can honestly show you how this level of service is the future. And it's not going away. It's not going away. We have an aging population with less practitioners to take care of them and more demand, and unfortunately, more of a reliance on medications to treat them. So there's less people looking at the meds than, hey, we got a problem. We got a problem, and it's around the corner. So for those in the senior care space, you can monetize and leverage stopping harmful medications as a potential revenue stream or an added value stream for your clinic. That is exactly what our accelerator program will show and teach you step by step. And so some of the barriers I had to overcome when I started doing this service for my patients one-on-one was showing, one, that pharmacists can do so much more than just count by fives in a pharmacy. So that took some re-educating, that took some patient trust and buy-in, and really showing the providers that we are here on as a team-based approach on the same level as just simply an extra pair of eyes to take care of our patient. It's as simple as that. I had to learn that my purpose in this world, at least in my calling, is to teach as many providers and clinicians on what they can do to literally leverage deprescribing. Again, I'm not telling people to just stop all your meds cold turkey and take a bunch of supplements. That is not the point of this program. The point of this program is showing that deprescribing is a multi-layered, multi-step process, which requires patient buy-in. It requires provider training and buy-in. It also requires pharmacist intervention. It requires those who have the skill set and knowledge to understand what meds are truly needed as you age, because our bodies don't work the same. So how can we expect the side effects or potential benefits to be the same years and years down the road? So I learned a lot in this world of providing deprescribing as a service for my business. I do it for all my patients. We provide genetic testing as well, so they're getting a piece of precision medicine. But I found that a lot of the work, honestly, starts with just advocating. It just starts with asking the right questions. It starts with giving a little bit of more time on wondering whether we really need all of these medications or not. So how can you start monetizing? There are tons of ways. You can do this with one-on-one direct consulting services. If, say, you are a pharmacist or a doctor, you can learn how to deprescribe safely. It also starts with education. In fact, you think our community really knows what the word deprescribe means? They don't. So why not teach them so that they know how to ask those questions when they're in a doctor's office? Because I still meet seniors to this day who feel like they can't even say what they want in clinic because they feel like they don't have the power or the backing or the clinical know-how or maybe even the support of their own pharmacists to really show them that, hey, you can ask doc, can I get off of these meds? I'm tired of taking so many pills. It can be done. It can be done. Now, it does help to know what are some of the signs of over medicating. Are your patients fatigued? Are they tired? Are they having constant pain and discomfort? Is there more confusion in their day? Are you seeing more falls? These are easy red flags that nurses and pharmacists can easily hone in on when they're doing their care reviews and use them as stepping stones to advocate for what is the problem with the meds if it's a medication related issue. Doesn't have to be a pharmacist. A lot of it is asking, are you on more than 5 medications? Do all those medications have a proper indication? And truthfully, what are we doing to minimize harm, knowing that their livers are changing, their kidneys are changing, the way their stomach absorbs drugs are changing? Are those drugs still appropriate now? And you'll learn evidence changes with time, and it's not going to always be appropriate. And this is why, again, deprescribing is the future of healthcare. Deprescribing can be monetized and leveraged to not only improve quality outcomes and metrics and reduce hospitalizations and readmission rates, and of course, those lovely HEDIS and HCPCS measures, whatever you want to talk about. If it's related to a medication that can potentially cause it, then why not act towards stopping harm before they hit the ER and cost our taxpayers another $100K or $50K for repeat offenders? It's doable. I guarantee it. I'm not the only one doing it. There are others who are using deprescribing as a selling point. But I want you to take away the gold, and I want you to choose the red pill. Wake up. All right. If I got to be called Morpheus for the rest of my life, so be it. Call me Morpheus, but I am the chief deprescriber. And I want everyone to be a deprescribing advocate and learn that pharmacists are your BFFs. We are your patient advocate. We're your caregiver advocate. And frankly, this is about serving a higher purpose. This is about serving a higher purpose. This is not about a sale. This is about stopping our seniors from being sent to the nursing home like my grandma was, and then eventually kicked out because of the same medication. It's about quality care. And I don't know why my 34-year-old self has to be so loud about this for the system to finally wake up. Wake up. The numbers are there. The numbers are there. So, do you want to choose the red pill or do you want to choose the blue pill? The blue pill symbolizes keeping the status quo, basically Neo before he was Neo, essentially just going to work, doing your 9 to 5. Oh, another patient admission. Oh, great. All right, let's do what we can. Or are you going to actually change your system, change your processes, and choose the red pill, which means you're trying to wake up and break through this awful healthcare system? I don't care how broke I go doing it, but I'm choosing the red pill. And I'm advocating for people to get off these medications until I die. Because if it happened to my family members, then I know for damn sure it's happened to tons and tons more. And we haven't even talked about the disparities when it comes to minorities in general. That's another whammy. That's a double whammy to the barriers that are faced when it comes to this. So again, I encourage you, ask your loved one if they are taking too many meds. If it's more than 5, have you asked your doctor lately, what can I do to safely stop this? What can I do to get off these meds? How can I change my diet and exercise to maybe get off of this or not suffer so much from side effects? It's doable, guys. And I will show you how as your chief deprescriber. So stay tuned for more. We're going to be doing quite a bit of videos in the next 3 weeks where we'll be detailing more information about our amazing Deprescribing Accelerator. We are going to start next month, June 3rd. Applications close May 27th. So if you are interested in applying, you can comment below either red pill or just go ahead and set up your application meeting with me with GeriatRx.as.me under Deprescribing Accelerator. So I look forward to meeting you all. There'll be tons more goodies. We'll have another show tomorrow discussing a bit more details about our program. But again, there's so much we can do. There's so much we can do. Anyone who touches a senior patient can integrate and implement and monetize deprescribing. Let me show you how. Stay tuned for more. This is, again, Dr. Delon Canterbury. Welcome back to our Red Pill versus Blue Pill series, your chief deprescriber and CEO and founder of GeriatRx. You guys take care, be well, and until next time.